We have a great webinar today with a lot of speakers, so we want to get started. Some people will probably be joining us as we start the introductions. Next slide, please. Okay, so today's webinar is being hosted by the Core Group Nutrition Working Group. If you aren't familiar with us, we seek to emphasize the critical role of nutrition in maternal and child survival and health through dissemination of latest information and approaches essential for quality nutrition programming. If you are not already a part of the Nutrition Working Group listserv, I will pop the link to sign up in the chat once we get underway. You can see our lineup of speakers today, and I'll give a little introduction before each speaker. So starting us off with opening remarks is Leslie Koo of USAID. She's a USAID Nutrition Team Lead in the Nutrition and Environmental Health Division in the Office of Maternal and Child Health and Nutrition, Global Health. Leslie, over to you.
Okay, thanks, Charlotte. Good morning, good afternoon, and good evening to all of our webinar participants. As Charlotte mentioned, my name is Leslie Koo, and I'm the Nutrition Team Lead in the Office of Maternal and Child Health and Nutrition at USAID. And I'm very happy to welcome all of you to this event focused on the critical importance of good nutrition for women. Meeting the health and nutritional needs of mothers before, during, and after pregnancy is essential to support women to achieve the best possible health and nutrition outcomes for themselves and for their children. But as we all know, in many countries around the world, the nutritional status of women is unacceptably poor. Far too many women cannot access the health and nutrition services and support that they need for optimal outcomes for themselves and their children. Additionally, many women cannot access a nutritious diet because of the high cost of nutrient-rich foods, gender inequity in their households or communities, and many other social, economic, and environmental factors. These barriers to achieving a nutritious diet put women and girls at a higher risk of malnutrition, which is further exacerbated in emergency or crisis situations such as the current COVID-19 pandemic. At USAID, we're encouraged by the recent Nutrition for Growth commitments by country governments and other stakeholders to improve maternal nutrition. And we are committed to working with our partners to improve women's nutrition across the life course through a variety of evidence-based interventions. These include nutrition counseling for women and their families before, during, and after pregnancy to promote the health of mother and baby, food systems transformation to provide safe and affordable nutritious foods for women and girls, protection of women's nutrition in emergency situations, and supporting women's and girls' access to education, income, and delayed marriage to provide them with more opportunities to thrive. So today's webinar focuses on the vital role of health services in protecting, promoting, and addressing the unique nutritional needs of women and mothers. While the 1,000 days from pregnancy through the child's first 2 years of life represent a period of critical growth and development of the child, it's also a period when women are most likely to have contact with the health system. And we can't overstate the importance of this window of opportunity for ensuring the best nutrition and health outcomes for mothers and babies. Nutrition is also not an additional element to be integrated into maternal health services, but should really be a fundamental component of all intervention platforms aimed to promote the health of women and girls. I'd like to express appreciation for our distinguished lineup of speakers today, who will be diving into the crucial how of making this a reality, and particularly our colleagues joining us from Guatemala, Kenya, and Uganda. And thank you to the Core Group's Nutrition Working Group for hosting this webinar. And thank you to all our participants joining from around the world to be part of this important conversation about supporting women to have the best possible nutrition to survive and thrive. So with that, I'll hand it back to you, Charlotte.
Thank you so much, Leslie. I also forgot to mention that we will have Q&A at the end. So if a question comes up, feel free to pop that in the chat as well, and we'll be collecting those. So next is Dr. Justine Covley, who is a public health nutritionist and the CEO of Guideline Consulting. And she was the former Maternal and Child Survival Program Nutrition Team Lead. Justine?
Thanks so much, Charlotte. Really appreciate the opportunity today to speak to you all about the development of the maternal nutrition operational guidance, and our experience from USAID's Maternal and Child Survival Program, MCSP. So I'd like to start off by taking stock of where we are globally for maternal nutrition. In the last 15 years, we know that overweight and obesity among adult women is steadily increasing, as shown in the gray. And there's been little to no change for anemia among women of reproductive age and pregnant women, as shown in the blue and the green lines. We also know that COVID-19 has exacerbated acute food insecurity and increased food prices, with expected increases in maternal malnutrition, micronutrient deficiencies, and women who are affected by anemia. Within this context, when we think about scaling up of maternal nutrition interventions and the service delivery platforms and packages needed to do so, there are nutrition-specific interventions such as counseling on maternal diet, weight gain during pregnancy, in tandem with breastfeeding support provided at antenatal care and postnatal care, both at facility and community levels, which is needed in conjunction with nutrition-sensitive interventions such as family planning, education, and social protection. USAID's flagship Maternal and Child Survival Program was implemented from 2014 to the end of 2019, and whose aim was to end preventable child and maternal deaths by improving the use and coverage of reproductive, maternal, newborn, and child health interventions in low and middle income countries. Nutrition was one of the many technical areas in the RMNCH platform, and we really sought to improve the quality of nutrition services at the facility and community level while keeping in mind the cross-cutting themes of quality, equity, BCC, and community approaches. MCSP worked at global and country levels to support maternal, infant, and young child nutrition initiatives by both generating and contributing to the global evidence, and then using that evidence to support country implementation and strengthening the quality of nutrition services within the RMNCH platform. And then also building country capacity across health systems for evidence and data for decision-making, for example, behavior change, training, supportive supervision, and mentoring. As part of global leadership, we sought to understand what were the barriers to maternal nutrition and translate that evidence to guide our programming at the country level. So we looked at the 25 low and middle income countries that were the USAID priority countries to identify drivers of food choice and consumption during pregnancy and lactation, examine issues and opportunities to improve maternal diet and weight gain during routine health contacts, and also to gain an understanding of what type of information and counseling were women receiving during pregnancy, and how does this dovetail with the 2016 WHO ANC guidelines. And what we found was that the evidence showed that there was a focus on implementation and evaluation of nutrition interventions, examining the benefits for child health and also for child nutrition outcomes, rather than looking or examining the impact on dietary intake during pregnancy and lactation. We also found there's little evidence on the type and quality of information and counseling provided to women on nutrition during pregnancy, and counseling on gestational weight gain was particularly weak. In addition, we found that there were drivers of food choice that stemmed from whether women believed foods were appropriate, whether they preferred these foods, and whether there were foods that they avoided. For example, women may understand there are the importance of good foods or needing to eat well, yet were unclear on what actions to take. Or they would limit foods to those that they thought would increase breast milk production, Or in some countries, there may be beliefs around the properties of certain foods, such as being a hot food that may harm fetuses or cause abortion. And even the quantity of food really varied. Some women eating less during pregnancy to avoid big babies, while others eating more postpartum for wound healing and to promote breast milk production. So in looking at that global evidence and examining that into and translating that into how we implement and look at country programs, the first learning we had was that we maximize opportunities that we had for revising infant and young child nutrition counseling materials in Egypt, Congo, and Tanzania. And here, we discussed with mothers and rolled out key messages around what mothers needed to meet their nutritional needs and support breast milk production. Mothers thought that their quantity of the diet that they consumed was linked to their quality of breast milk. And so we dovetailed that with messaging and information around breast milk production. Secondly, in Mozambique, we had an opportunity to develop national anemia counseling materials when we noted in a rapid facility assessment and in qualitative formative assessments that women did not have information on the benefits of iron folic acid supplements. They didn't understand the side effects or even the purpose of IFA. And so we worked with the Ministry of Health to develop these counseling materials, which were lacking in health facilities. Third, we also had an opportunity to integrate maternal nutrition into e-learning courses, which we'll hear more about today from our colleagues from Guatemala, but also we rolled this out in Ghana and Zambia as well. So these key country learnings, along with the global evidence review, were then utilized to formulate the maternal nutrition operational guidance, and also we distilled a briefer on the WHO ANC care guidelines. And so this involved several steps. One, determining available data that you have in terms of what is known about maternal nutrition from the perspective of mothers, key influencers, and health providers, even looking at survey data regarding maternal dietary diversity. Secondly, determining priorities with regards to how it aligns to national nutrition action plans, your funding that you have available, what implementing partners are doing, and so forth. And for step 3 is to collect data to design and/or adapt interventions, either to advocate for maternal nutrition, adapting existing interventions, or introducing new interventions to improve dietary diversity or to address maternal anemia, for example. Those could include examining norms and beliefs, examining actors or actions that are taken, looking at the content of counseling materials or the lack thereof, and looking at demand and supply side for micronutrient supplementation. And step 4 is to develop and adapt interventions based on the other 3 steps. So strengthening nutrition, health integration across the continuum of care requires approaches that strengthen interventions at the facility level, through antenatal care, through postnatal care, and even through child visits, where we could maximize even incorporating maternal nutrition into cooking demonstrations. And that is in tandem with community level approaches such as support groups or home visits, and even the baby-friendly platforms. And that's in tandem with multi-sectoral engagement where possible through agriculture, water and sanitation, social protection, and early childhood development. What we learned from our years of implementation at MCSP was that pre-service training is really critical as a foundation for integrating maternal nutrition into curriculums for health providers, including midwives and nurses. While we emphasize more on in-service training to support counseling, which often was lacking or required updates, we did focus on site training and mentoring, which we felt was needed for quality. though with the understanding that pre-service training is also needed. Routine health contacts were missed opportunities to provide counseling on maternal diet and weight gain during pregnancy. And formative assessments were really key to integrating and improving what we do at community and facility level. While we didn't have as much of an opportunity to engage with other sectors in this health project, we think that that would be a logical next step to integrate and expand maternal nutrition between nutrition sensitive and nutrition specific interventions. Finally, more information is needed on the impact of programs that include maternal nutrition interventions, and that is a data gap that should be addressed in the future. Thank you very much. We have all our resources still live on the MCSP website and are also cross-referenced at Cavley Consulting.
Thank you so much, Justine. Next up, we have Kristen Cashin, who's the Director of Nutrition and Health Systems at USAID Advancing Nutrition. Go ahead, Kristen.
Thank you, Charlotte. For the next few minutes, I'll be describing a recently completed program planning guide called Strengthening Maternal Nutrition and Health Programs, a Guide for Practitioners, which was developed in 2021 by USAID Advancing Nutrition and builds on lessons learned from using the maternal nutrition operational guidance that Justine just described during the program planning process. It's currently available in both English and French. And next slide, please. So although it was developed based on country implementation experience, the maternal nutrition operational guidance and checklist itself had not been tested as a complete tool for program planning. So working together, USAID Advancing Nutrition and the USAID Maternal and Child Health and Nutrition Activity in Uganda integrated the operational guidance and used the checklist during the MCHN activities program planning phase in order to identify and design priority interventions for maternal nutrition in Uganda, and through using it to identify its strengths and gaps as a program planning tool and recommend ways to strengthen the guide to support program planning for maternal nutrition. Today, I'll focus on the lessons learned from using it as a tool. The implementation priorities for Uganda were the subject of a December 2020 USAID Advancing Nutrition report and a February 2021 webinar on the topic. And after my presentation, I can put links to those in the chat, so anybody who's interested in those can also explore them. So in order to test the operational guidance, while using it, we observed the MCHN activities use of the guidance, and then we interviewed team members on their experience using the guidance and how integrating it into their baseline assessment, their ongoing processes, identification of documents for desk review, identification of research questions, adapting key informant questionnaires, and suggesting indicators for secondary data analysis. We asked questions about how the use of the guidance affected their team decisions and process, how it helped or hindered the maternal nutrition program planning, and what changed as a result of using the guidance. Next slide, please. So our key takeaway was that this experience of using the maternal nutrition operational guidance improved the maternal nutrition component of their baseline assessment and helped ensure that maternal nutrition was considered comprehensively in program planning. Specifically, people who used it really appreciated the step-by-step guidance, that it helped refocus their efforts to more comprehensively include maternal nutrition, and the useful information and resources that were included. And they also appreciated that it helped identify gaps and where to focus and built on existing frameworks, data, and interventions. Users said things like, the guidance provided step-by-step planning from review of the current policy environment, identification of gaps in implementation, and stakeholder engagement and buy-in to planning rollout and monitoring changes. And another pointed out that although our initial plan was to collect data on MCHN, the guidance helped us to refocus and sharpen our existing tools to capture maternal indicators. Next slide, please. But there were also several recommendations for revising the guidance to better support program planning. These included that participants requested that the guidance follow an overarching simple program planning process to guide the structure of the steps. They wanted to make sure it emphasized tailoring to reflect specific country contexts and needs. And they wanted information, simple, straightforward information on how much time it takes to complete the process and what skills are needed to do the process. They found that the language and order of information was sometimes confusing and also wanted more information on key maternal nutrition areas, such as more guidance on a life cycle approach. Related to data collection, they requested more guidance on where to find the data described in the checklist, clear examples of data sources, case examples, data collection methods, guidance on tailoring data collection to the context, how to access existing data, what types of data and levels of disaggregation, as well as more guidance on understanding the structural environment and barriers influencing behaviors. And then after that, they wanted to know more about what to do with all this information and what it means. For the enabling environment, many nutrition programs play a role in evidence-based advocacy for strengthening systems, improving governance and accountability, and mobilizing resources. So users requested additional information on when and how to include actions to strengthen the enabling environment, and also wanted some country case examples. They also wanted it to emphasize the importance of a participatory approach and consensus-based implementation planning that involved multiple stakeholders and especially government counterparts. And they requested for more tools on collecting and analyzing data, social behavior change, training, mentorship, monitoring and evaluation, quality improvement. They wanted, basically from this document, they wanted more access to specific and useful tools for program planning. Next slide, please. So based on those findings, we developed a new tool, a new guide called Strengthening Maternal Nutrition and Health Programs, a guide for practitioners. It was reviewed by global and country-based experts who've shared feedback and recommendations, both in written form and through a virtual online consultation. The document was finalized in September 2021 and is available in English and French. It provides step-by-step guidance to add or strengthen maternal nutrition components in programs and services delivered by the health system. It targets non-governmental organizations who are working closely with government counterparts and are seeking to strengthen maternal nutrition at the facility or community level, or to strengthen the enabling environment. It is recommended that people use this 3 to 6 months before planning a new program or activity or applying it to an existing program activity. And the key changes we made were that it now follows a 3-step program planning model, which includes a situation analysis, developing an implementation plan, and implementing, monitoring, and adjusting. It's a slight change from the 4 steps of the operational guidance. It includes expanded guidance on data collection and synthesis. It includes illustrative approaches to strengthen the enabling environment for nutrition. And then there are links to additional templates, tools, and resources. Next slide, please. So this is the checklist that outlines the steps included in the guide. Within each step, we provide guidance and resources that help users to complete that step. The situation analysis step helps users have enough information to identify priorities and appropriate interventions and approaches. It includes guidance on priority maternal nutrition areas for data collection, sources of data, a discussion of formative research, and considerations on quality, dietary diversity, gender, discussions of reviewing existing programming and country guidance, as well as guidance for synthesizing the data. The section on identifying maternal nutrition priorities and developing an implementation plan reminds the planners to really consider key collaborators to work with to discuss the priorities, including government and technical working group members, people within the health sector, as well as multi-sectoral stakeholders. And it includes potential implementation priorities and illustrative approaches to help fuel discussion among that group. And then the implement, monitor, and reflect section includes guidance on process indicators and adaptive management to help with continuous learning. And all 3 sections include brief case examples. Next slide, please. There are also 7 annexes that support each of the steps. There's information on indicators and data sources, collecting and analyzing data, a very long list of links to tools and resources that include key evidence, social behavior change tools, situation analysis tools, adaptive management resources, programming in the COVID-19 context, program reports and briefs, and multi-sectoral approaches. There's also a summary of global guidance, and then links to help with the process, workshop agenda, theories of change methods, and implementation plan. Next slide, please. So you can find these on the USAID Advancing Nutrition website. I'll also include links to all of the resources I mentioned in the chat. And thank you very much.
Okay, thank you so much, Kristen. And now we're going to hear about some experiences from country programs. First, we have Ms. Rael Wando, Kisumu County Nutrition Coordinator at the Ministry of Health in Kenya. Go ahead, please.
Thank you so much, Charlotte. I'll be presenting on strengthening the integration of maternal nutrition through the MCSP country program experience from Kenya. Next slide, please. So this is the presentation outline. We'll be able to look at the background, what and why BFCI, the BFCI implementation package that we are using in Kenya, BFCI monitoring, how we monitor both the infant and the maternal nutrition indicators, the BFCI entry points for maternal nutrition, and integration of maternal nutrition. That is the opportunities, challenges, and lessons learned. Next slide, please. So we can see that Kenya has been able to make some tremendous progress in improving a number of indicators, but still lags behind in certain indicators. So far, in terms of women nutrition, it is an area that is a bit neglected, because when we look at there is no progress in reducing anemia, and so far affects 28.7% of women aged 15 to 49 years. We know that high prevalence in anemia among women of reproductive age leads to poor maternal and fetal outcomes. There is also limited progress on obesity, which affects 13% of adult women. And we know very well the high prevalence of obesity implies an increased risk of non-communicable diseases among the affected women. However, there is marked progress in infant and young child nutrition. In exclusive breastfeeding, we can see that comparing the 2008 Kenya Demographic Health Survey and 2014 Kenya Demographic Health Survey, there is significant improvement. Kenya was at 32%, and in 2014, we were able to improve to 61.4%. This is attributed to some of these interventions like baby-friendly community initiative. Stunting and wasting, Kenya is also on track. Stunting, we were at 35%, and we've been able to reduce this to 26%. Wasting, we've moved from 7% to 4%. The map shown indicates the various areas in Kenyan country where baby-friendly community initiative is being implemented. It's good to note that not all counties in Kenya are implementing the baby-friendly community initiative. Next slide, please. So baby-friendly community initiative is a community-based initiative that protects, promotes, and supports optimal breastfeeding, optimal complementary feeding, and provides a platform to strengthen maternal nutrition intervention, which is a key challenge that we are currently facing. It works through formation and the training of the mother support groups and close link to the health facilities. It focuses on nutrition-specific and nutrition-sensitive interventions. Nutrition-specific interventions are those approaches that focus or address the immediate causes of malnutrition, and these are like exclusive breastfeeding, complementary feeding, micronutrient supplementation, and the like. While nutrition-sensitive interventions are those approaches that address underlying causes of malnutrition, and these are like kitchen gardening, liaising with the ECD programs, and WASH program. Next slide, please. So the question is, why BFCI? So World Health Organization and UNICEF recommends expansion of the 10th step to the community. This 10th step is the 10th step for the baby-friendly hospital initiative, which is an initiative that aims to give every baby the best start in life by creating a healthcare environment that supports breastfeeding as a norm. So baby-friendly community initiative expands on this step, on this 10th step, to create community and supportive structures for the mothers to continue breastfeeding. So on discharge, we realize from the hospital, mothers require continuum of care. So baby-friendly community initiative helps to sustain the gains made at the hospital by the baby-friendly hospital initiative. It also provides a platform during the continuum of care from pregnancy until the 2 years of age. That is the first 1,000 days of a child's life. Next slide, please. So in Kenya, we have an implementation package. We have a training manual for the healthcare workers. We have a manual for the community health volunteers. We have counseling cards that are used by the community health volunteers during the home visits. We have the first 1,000 days booklet, which is given to the mothers for them to be able to refer to the information given to them during the mother-to-mother support group meetings. We also have a supervisory and mentorship guideline that is in a book. And this is so far has been revised. The latest is in July 2021. Next slide, please. So during implementation of baby-friendly community initiative, it provides linkage from community to facility so that when mothers are delivered at the facility, they can be referred to the community so that there is that continuum of care, and for the community, they can still also be referred back to the facility. So there is the capacity building for facility and community on BFCI. This is through the approved curriculum. Then there is the monthly community health volunteers meetings. We have mentorships and targeted support supervision, which is done by the county health management team and the sub-county health management team, the targeted home visits by the community health volunteers, the baby-friendly community meetings, the community dialogue and action days. Then we have education sessions, which are conducted through the support groups and counseling at the clinic. Then at the facility, there is the establishment of the mother baby-friendly resource centers and the baby-friendly breastfeeding rooms for the mothers when they come to the facility, both at the facility and at the community level. Next slide, please. So during implementation of baby-friendly community initiative, documentation is key, and this is done at all levels. A set of tools are used for reporting the indicators. There is Form 1A, which is used to document individual infant and young child feeding and growth monitoring record. This is done by the community health volunteer, and then the information is summarized by the community health extension worker. So the first 4 indicators that are on the screen are monitored on monthly basis, while the last 2 indicators are monitored after every 6 months. This is just to avoid duplication. Next slide, please. The other set of indicators, which came about in the first phase when we were implementing baby-friendly community initiative, we did have a set of indicators that we are following up for the mothers. So upon recommendation, then there was the tool, which is Form 1B, that was developed for individual mother records. This one, a mother is followed up for 9 months during pregnancy, and then 23 months after delivery. A set of 7 indicators are monitored. The first indicator is on nutrition status of the mother using the mid-upper arm circumference. Then there is iron folic acid consumption, the iron received and the iron consumed. Then there is the consumption of food from the 10 food groups, and then the consumption of the recommended meals for the pregnant women. We know that the pregnant women, the recommendation is they're supposed to take 6 meals in a day. That is 3 meals, 2 snacks, and 1 small extra meal. And for the breastfeeding mothers, they're supposed to take 7 meals. That is 3 meals, 2 snacks, and 2 small extra meals. So these indicators are monitored on monthly basis, and the data is collected by the community health volunteer. The information given on counseling is also monitored on monthly basis. Next slide, please. So how can the Bfci platform address maternal nutrition? Next slide. So we have the various entry points for Bfci to strengthen maternal nutrition given the challenges. During the antenatal care, the mothers are given nutrition counseling on the dietary diversity, on the benefits of iron folic acid and the side effects of iron folic acid and how to manage the side effects. During the postnatal care, the same information is also provided. And now we also add information on importance of breastfeeding. Then during the child visits also, information is also given to the mother on family planning. On family planning, issues of infant and young child feeding are also provided. Then during the home visit, the mothers are also provided information on dietary diversity, mid-upper arm circumference is collected, and then information on iron folic acid is also given. At the community level, there is also that opportunity during the mother-to-mother support group meeting. The same information given at the facility level is reinforced at the community. And we see that for us to be able to achieve in a baby-friendly community initiative, multi-sectoral engagement is key. And key departments here, we have agriculture, we have the education, social protection, and WASH program. Next slide, please. So what are the opportunities to leverage for Bfci? We have the counseling on maternal nutrition and anemia as part of ANC package is an opportunity for us to be able to make some steps in terms of improving maternal indicators. Then encourage mothers to attend ANC during the home visits and during the mother-to-mother support group meetings. These are platforms where mothers can be encouraged to adhere to the ANC visit as per the recommendation, and even during the mother-to-mother support group meetings. Then maternal nutrition messages are provided. Benefits iron folic acid during the ANC and home visits are reinforced. How to improve maternal dietary diversity through the kitchen garden, where we work closely with the Ministry of Agriculture, and how to improve maternal diet through cooking demonstrations that are done during the mother-to-mother support group meetings. Next slide, please. So the challenges are: one, there is that weak facility to communicate. Weak facility community linkages can translate to less referrals to ANC services and CHP motivation for follow-up. Then inadequate coverage of Bfci in communities. From the previous slides that we have seen, not all counties are implementing Bfci. Then the workload for the CHVs. The community health volunteers are the ones that collect this data at household level. And it's not just on BFCI. There are a number of programs where they are required, and this can actually is really a big challenge on the workload for them. Next slide, please. So what are some of the lessons learned? So we have learned that addressing maternal nutrition within the context of community platforms indeed can be effective, because given the various activities where we are interacting with the mothers through the mother-to-mother support groups, community dialogue days, mothers can be able to take up some of the actions that can help them improve their nutrition status. Then the use of mother-to-mother and community support groups can add to counsel on what foods mothers should consume and why. So these are platforms that we have in the BFCI that can help address issues of dietary diversity. Then engage community members, and in BFCI, we engage all the women, the fathers, and everyone is key. And this can help help mothers improve the ANC attendance and incorporate cooking demonstrations. Then the use of multi-sectoral approach for implementation is key to sustaining the gains made, because we realize that for us to be able to sustain the gains made, we need all the sectors, because they are very key in implementation of baby-friendly community initiative, because each sector plays a critical role. Agriculture plays a critical role when it comes to kitchen garden, to be used for demonstrating on issues of dietary diversity, and education on stimulation and early childhood development. Next slide, please. I want to acknowledge the Ministry of Health, Division of Nutrition and Dietetics, Kenya, Kisumu County Government, Migori County Government, and USAID Maternal and Child Survival Program. That is Ms. Brenda Ahoya, Nutrition Advisor from Kisumu County, and Constant Gadi, Nutrition Officer, Migori County, for the work that they were able to support for successful implementation of BFCI. So asanteni sana, thank you. We can be able to get all this from the link. Thank you, and over to you, Charlotte.
Thank you so much for that great presentation. And now we're going to ricochet around the world to Guatemala and hear from Maggie Fisher, the Chief of Party of the Health and Nutrition Project at Chapaigo. Go ahead, Maggie.
Thank you, Charlotte. So on behalf of Guatemala, we would like to thank the opportunity to present USAID's contribution to capacity building efforts in maternal health and nutrition in Guatemala. This presentation has been made with Norma Alfaro Fonica and her team, Irene Corrado, Gustavo Arroyo, Wilton Perez, with Sandra Vecinos, who's currently the nutrition advisor for the Health and Nutrition Project, myself, and with the support and guidance from Justine Covley. I would like to take the opportunity to thank USAID's trust and support throughout these years for these efforts, particularly of Romeo Menendez, who has been the AOR under MCSP as well as the current one, and the trust and openness of the Ministry of Health, particularly the Vice Ministry for Primary Healthcare, and the health areas and health districts where these diplomados have taken place. Next, please. The presentation will focus on firstly on presenting key maternal and child indicators reflecting the stunting levels and the considerations of maternal nutrition. Based on that, what were the considerations and the need to develop a diplomado to strengthen capacities, describe the diplomado to enhance the skills competencies of primary health care workers, as well as present results and achievements, and guide and share next steps that we are proposing that need to be taken into consideration. Next, please. In this slide, we can see that Guatemala, despite the fact that it is a middle-income country, has very high levels of stunting. I would say among the highest, 8 worldwide, and the highest in Latin America. And because of the fact that Uganda is also presenting, I included, you can see that Uganda is here, but Guatemala is way up. Thus, economic growth is good, but not good enough in order to reduce stunting and to promote best nutrition among key groups. Next, please. Here are some of the key indicators that I have chosen to reflect what the current situation is and reflects what the key challenges, if you may, are in regards to improving the maternal child situation in Guatemala. Due to timing, I will not address each one, but would like to focus on low height of women, which is Guatemala presents the highest, worldwide. Guatemala has the shortest women, the height for women, and which is a risk factor, if you may, for low birth weight. It is a risk factor for pregnancy. It is a risk factor for women not wanting to gain weight during pregnancy. Additionally, we have about 24% of adolescents who are already pregnant. Likewise, in regards to prenatal controls, 35% of households have less than 4 prenatal controls. Births at home in the Western Highlands, we see that 60% do take place at home, presenting a higher risk for these births. And as you can see, the double burden of malnutrition, where you have a stunted child and an overweight woman, is of 20%, and we have 50% of overweight women. In regards to stunting, the last DHS reflected 46.5, which where one of two children are stunted. In the Western Highlands, 68%. Next, please. Because of the fact that in Guatemala, the Ministry of Health has taken the lead, if you may, for addressing nutrition-related interventions, and based on the indicators presented earlier, we have focused on promoting an integrated approach to address the reduction of stunting, but focusing at this presentation on the importance of having competent frontline health workers to provide quality nutrition services. But we fully understand that it is not enough to have competent providers. There is a need to have an enabling environment for which to promote and implement the activities, as well as to have strategies to increase demand and trust of health services. Thus, partnership-defined quality approach and the wheel of practice are some of the tools that are being used in order to increase the demand of services and to promote the linkage between community and health services. And evidently, the need to have supplies, medicine, folic acid, iron, as well as anthrometric equipment, among others, in order to provide services. Next, please. Now, due to the earlier situation described, nutrition has been seen in Guatemala as a key intervention to address the vicious cycle of stunting. And it was based recognizing the Lancet series, the Copenhagen consensus, the world evidence that there are cost-effective evidence-based interventions that need to be taken into account. Plus, the norms and regulations of the Ministry of Health made it appropriate to have and use the Ministry of Health as a platform to target the frontline health workers to improve their capacities, their attitudes, as well as their knowledge to provide nutrition and health-related services, particularly in areas where there is high levels of stunting. Next, please. So what did we do? In collaborate, USAID with its implementing partners and with INCAP, we designed, developed, and implemented a diplomado targeted to frontline health workers in the Western Highlands, which presents the highest levels of stunting. This resulted in the Maternal Child Nutrition Diplomado focusing in the first 1,000 days of opportunity. Next, please. The contents of the diplomado had 9 modules. In this presentation, I will focus on nutrition during pregnancy because of the scope of this webinar, but it did have other contents. Now, the nutrition during pregnancy module focused and addressed aspects pertaining to capacities to assess nutritional status of pregnant women, to address minimum weight gain during pregnancy and the importance of weight gain during pregnancy, recognizing that the weight gain is an issue and concern for pregnant women, particularly because of beliefs that they have, because of their low height, among others, because of access to nutritious foods. The other content included in this module referred to clinical evaluation and also focus on guidance on diet and nutrition using food-based recommendations that were developed with USAID support under FANTA and with INCAP. Another key content was micronutrient supplementation, which referred to the importance of micronutrient supplementation, particularly of iron and folates. It is worthy to mention that micronutrient supplementation represents a challenge not only in terms of logistics and its availability in the health services, but also represents a challenge that women do take and consume the supplement due to existing barriers, due to existing beliefs that hinder compliance of micronutrient supplementation. And an additional concern area that was addressed was related to physical activity. In Guatemala, in some of these areas, women have to carry water to have available of water 3 to 4 hours. So physical activity is a concern during pregnancy, not only during pregnancy. The other module that was of utmost importance was of self-esteem, not only of women, but of the health providers. What was the importance of this diplomado? First of all, the strengthening of in-service training as well as the pre-service training, linking and incorporating these contents in universities that provide targeted to physicians, nutritionists, nurses, auxiliary nurses, and even agronomy to link nutrition-specific and nutrition-sensitive interventions. Likewise, the availability and provision of tools and job aids for provision of quality nutrition services. And one key aspect that I would like to enhance and highlight about these diplomados have been that the learning modality and time span allows for deeper understanding of nutrition. There was a trend to take out workers out of their work to attend workshops. Through these diplomados, the personnel do not have to leave their site, do not have to be on continuous workshops, but rather can take the diplomado. Next, please. These are the materials that were developed and highlighting pregnancy, not only pregnancy during adolescence, but also pregnancy of adult women, self-esteem, diet diversity, child nutrition. There were 8 courses, 8 contents, 8 modules, water and sanitation, among others, that were addressed. In the upper part of the slide, you can see the materials that were developed for the participants, whereas in the bottom, for the facilitators who had special materials developed so that they could use it. Despite the fact that the intent originally was to have virtual training, due to technological capacities and lack of availability of internet in the areas, we had to move in the early phases to printed material instead of using INCAP's virtual platform. And we also used USBs. Next, please. The target audience included auxiliary nurses, health technicians, health promoters, and they were trained through facilitators. There were different phases that were used for the diplomado, and the study circles that were used to review and discuss each of the modules were of utmost importance for the exchange of knowledge, concerns, questions that arose among the participants. And in the bottom of the slide, you may see the transition that occurred with the development of the diplomado from in-person training to hybrid methodology using study circles, virtual training, and in-person meetings. Next slide, please. These are some photos of participants in the study circles, as well as one of the groups that finished the course and one of the training for feeding practices. The next, please. In this slide, you can see the evolution, the timeline that has occurred for the training, and which started in 2015 and currently under PSN. The number of participants is highlighted, men and women, and a total of 1,855 health personnel have been trained throughout this timeline, with 194 certified facilitators. You may notice that currently we are only involved in 2 departments, Guatemala and Uganda, in view of the fact that USAID has prioritized those 2 departments with the highest stunting rates, with the highest maternal mortality, and with the highest neonatal mortality, reaching 21 health districts, 3 health areas, versus the 3 former cohorts that had 5 departments with 30 municipalities. Thus, the intensity and the focus, we are much more focused currently and to reach the target audiences. The next, please. Under USAID MCSP projects, there was a qualitative assessment carried out to better understand what were the perspectives, the advantages, and how different audiences were looking at the benefits of the diplomado. Local stakeholders, facilitators, and providers were interviewed, and each provided insights in terms of areas of improvement and areas of strengthening for the diplomado. But in summary, we can say that the diplomado was very well accepted. The next one, please. Here is the change of knowledge that has occurred throughout the course. Throughout the diplomados, there has been a dramatic increase in knowledge in each of the diplomados. The next one, please. And the key highlights that I would like to mention is the stewardship role of the Ministry of Health. Secondly, the innovative virtual platform that is currently using, we are moving on so that the Ministry of Health can have the diplomado and the credits provided as part of the continuing education. The next, please. As an incentive. And finally, as next steps, we recommend and consider the importance of strengthening knowledge and skills related to nutrition during adolescence, maternal nutrition, and pregnancy, to identify approaches to incorporate or address the triple burden of malnutrition, to expand the diplomado to new audiences, for example, communicators and other key players at the local level, combine approaches to build community capacity, so that should include diplomado, mentorship, supervision, and community of practices, and furthermore, to look the feasibility to certify health services in order to have quality nutrition and health services. I think that is the last slide. Thank you very much for the opportunity to share the experience of Guatemala, undertaken by USAID, its implementing partners on INCAP, with the stewardship role of the Ministry of Health. Thank you.
Thank you so much, Maggie. And now for our last presentation, we're going to go back across to Uganda. We're going to hear from Juanita Nagadia, Health and Nutrition Technical Advisor for Catholic Relief Services, and Wilson Kiribira, MCHN Manager at Mercy Corps. Go ahead, please. Juanita? Or
Juanita, you're on mute.
Okay, sorry. Yes, hello everyone. Thanks, Charlotte, for the introduction. In this presentation, we are going to take you through how New York activity and Apple activity have been able to contribute to improving maternal nutrition through the Ugandan community health system, a Karamoja experience where the programs operate. For this presentation, we are going to have a brief overview of the maternal nutrition context within Karamoja, also look at Apple and New York activity overview, highlighting the community health structures and project approaches that the activities have used. In addition to this, we shall also highlight the key outcomes, factors for success, and challenges. Next slide, please. When we talk of maternal nutrition within Karamoja, according to the Food and Nutrition Assessment of 2020, it came out that 2.3% of the women of reproductive age had severe acute malnutrition, with 41% having moderate acute malnutrition, while 37.9% had anemia, as compared to 32% at national level. Next slide, please. So what is New York and Apollo? New York and Apollo, these are sister programs that are funded by USAID, Bfci, and they have a common goal of improving food and nutrition security for vulnerable households within Karamoja region. As you can see on the map on the left of the presentation, where you see that small map, that's Uganda. And in the northeastern part of Uganda, where you see yellow and pink, that is the Karamoja region. So New York and Apple activities operate in the entire region of Karamoja. Where you see yellow, the 5 districts, those are the operational areas for Apple activity. And where you see pink, those are the operational areas of New York activity, 4 districts within the region. Within this region, we work with agro-pastoral communities, thus bringing in unique challenges to integrating maternal nutrition into the community health structure. These are integrated programs that have other interventions taking place, as you can see down here. We have gender and governance, resilience, livelihood, health and nutrition, and WASH, all contributing to improving the food and nutrition security of vulnerable households. Next slide, please. I'll now take you through some of the approaches that New York and Apollo have used to ensure proper integration of maternal nutrition into the community health system. Among these, we have the community health structures and also the project-based approaches. When we talk of the community health structures, we shall start with the health unity management committees. These committees are found at each and every health facility within the Ugandan health structure. So their main role is to ensure proper monitoring and planning for health service delivery at the health facility level. So what New York has done, New York and Apollo together, we've been able to train the health unity management committees and sensitize them on the need to prioritize issues of maternal nutrition while micro-planning for service delivery at the health facility level. Next, we have worked with the village health teams. The village health teams is the last mile of the Uganda health system. So these are frontline health workers. They are community health workers. And within the Ugandan health system, they are called Health Center 1. So it's not a building, but these are people, community health workers, volunteers at community level, who reach out to mothers in vulnerable places with key health and nutrition interventions. So what New York and Apple have done is to train the village health teams on maternal nutrition issues and also equip them with key training guidelines to use as they reach out to mothers with the same training and sensitization. We have also, together with the district health teams, worked together to mentor and offer support supervision to the village health team structures so that they are able to offer better services to the mothers at community level. In addition to that, we have also equipped them with referral forms so that they are able to increase the number of mothers who are being referred to health facilities for specialized health care. New York and Apollo have also worked with the health facilities within Karamoja region to bring to scale the integrated health outreaches approach. Through this approach, health facilities are able to reach out to mothers in hard-to-reach areas with essential health care. So what New York and Apollo have done is to equip the health facilities with key anthropometric equipment to enable them reach out to a wider population of mothers and offer nutrition assessments. Through these integrated health outreaches, we also reach out to mothers with supplementation and also other health services. I'll now hand you over to my colleague, Wilson Chilavida, who will take us through the project-based approaches. Over to you, Wilson.
Thank you so much, Juanita. Hello all. Wilson from Mexico, Apollo. The mother care groups. This is a key approach where mothers that are pregnant, lactating, and taking care of children that are under 2 meet to discuss maternal nutrition. The formation of these mother care groups are by the activity staff helped by the government leadership, and under these groups, the mothers receive timely and targeted counseling from their peers, and the VHTs that Juanita has highlighted in the previous slide also help to link the mother care group to the health centers. Also, from evidence and observations and formative research, we have seen that the mother care group approach has been successful in ensuring the adoption of recommended maternal nutrition practices. So as Apollo and New York, we lobbied Ministry of Health to adopt the mother care group approach, and it has been adopted to use in the recently launched national guideline of maternal infant adolescent nutrition guideline. Also, the male change agents, we have seen that the involvement of men in maternal nutrition and health programming is very critical. Several male change agents have been trained in communities, and they are champions and influencing others to support in maternal nutrition, including supporting their wives to attend antenatal care, and also some of them always participate during delivery. Adolescent safe spaces, different spaces, safe spaces are existing in communities where adolescents of 10 to 19 years come and learn numeracy, they learn literacy, and additionally, they get nutrition education and assessment, and also get messages about sexual reproductive health and general health. And through these messages, they are being able to, it has been able to increase their demand for health services. Next slide, please. By leveraging outputs from other sectors, especially the livelihood sector, where there is opening of roads, it has been an advantage that roads have helped to break down the geographic barrier of accessing health services. So women that are pregnant can freely move to the health centers to seek antenatal care, postnatal care, and ensure they also deliver at health centers. Also, these roads that are being opened help women to be able to access markets where they buy the diverse diets. Also, working with the financial inclusion and economic empowerment sectors of both programs, New York and Apollo, the women under the mother care groups have learned saving so they can have always money in their pockets to meet the critical needs of health and nutrition, and also buying diverse foods. Next slide, please. Last year, at the end of the implementation year in September, both programs conducted the program surveys, and we have observed from the New York participants, we have observed an increase in minimum diversity for women, and also about 65% of participants reporting to receive health and nutrition services. And from the Apollo participants, about 98% of Apollo-supported mothers that were pregnant received at least the 4 antenatal care visits, and a good majority were satisfied with the health services at the health center and at the outreach posts. Next slide, please. These are some of the factors that are leading to the success that we have discussed above. As a country, we have very good policy framework, particularly linked to maternal nutrition is the Uganda Nutrition Action Plan 2 that is guiding all partners, government and private, to ensure that malnutrition programming is integrated across all sectors. And also the recently launched maternal, infant, young child and adolescent nutrition guidelines that are involving all sectors, all sectors and sector players, both health and non-health, to ensure delivery of appropriate and recommended maternal nutrition messages. At national and regional level, here in Karamoja, we engage with partners and governments, both national and local level, to plan, implement, and jointly do technical backstopping to the different nutrition interventions. Also, for motivation of communities and then the system actors, we have done several capacity building sessions to this, and also we adopted the use of in-kind motivation and not the financial motivation that causes dependence. And this has kept the motivation of the communities to involve in the different activities and also the system actors. We continue to support the linkage between the community and the facility, especially using the VHT that we discussed up in the different slides. Last slide, please. This is a summary of the key challenges, knowing that the Karamoja community is agro-pastoral. There is always movement, and these movements end up putting some women that are pregnant and lactating in places that are far away from health facilities. Also, there is insecurity, mainly caused by cattle raids that happen between the different tribes. And these cattle raids, whenever there are cattle raids, the government forces come in to pursue the raiders, including sometimes exchange of firearms. So this, during the exchange, this sometimes makes the communities fear access health services. Human resources, staffing across the 9 districts is at about 70%, and this affects the quality of service delivery. Also, COVID-19, especially at the onset around 2020, where mothers had all the fear and the movements were too restricted, they could not be able freely to access their services, even those that were pregnant or those that wanted support around breastfeeding. Social distancing, this one mainly affected the community facilitators in that they were not able to go to homes of mothers that need critical service, like supporting them to position and attach their babies to the breast. Thank you so much.
Thank you, everyone, our speakers, for their concise yet packed presentations, and for technology for working. So always don't want to take that for granted. We now have about 15 minutes for questions, and I have been collecting some from the chats. I encourage, if you can, our speakers to come on video so you can see your lovely faces. So yeah, there are a lot of good questions. And I think I'll just start out with, and this is for anyone, is for countries that are facing a double burden of malnutrition, are there any experiences with adapting messaging in order to address those unique challenges? Is Anyone who'd like to take that question?
I can start.
Okay.
Yeah, thanks so much for that question. I think that we have had some experience with developing some messaging around processed food consumption for women, especially unhealthy snacks, sugary drinks, which are becoming a larger feature of maternal diets. So I think that's really important to emphasize alongside adequate maternal dietary intake and to avoid those foods or at least reduce consumption of those. So we have integrated aspects of that into some of our programming under MCSP, although we didn't do as much as we would have liked to. But I think that's definitely an emerging issue that should be addressed given the double burden.
Great, thank you. Any of our country programs? Donita, Wilson, Maggie, Rael, do you have anything to add to that? Any of your experience? Go ahead, Maggie. Well, Maggie, I see your hand up, but I don't hear you.
Okay, sorry. In terms of double burden, I think there are common strategies that could be used to address the double burden. For example, breastfeeding practices for the child could be of utmost importance as one key strategy. I think the diet diversity and consumption of healthy foods, as Justine said, is also another one. So the linkage between nutrition-specific and nutrition-sensitive interventions could be of utmost importance. How to promote food-based dietary recommendations to increase healthy foods and reduce snacks that are not nutritious. So just to add to what Justine said. But to me, it seems like it's the recommendation and the linkages which needs to integrate nutrition specific with nutrition sensitive interventions. Over.
Yeah, thanks, Maggie. I just wanted to also add on that one of the highlights that the presenters also mentioned was that how do we leverage infant and young child feeding programming? So if we are bringing mothers for cooking demonstrations on complementary feeding, you have a captive audience already. So you can already discuss with mothers. For example, in Kenya, we taught mothers, how to not overcook vegetables, but also they are eating, fried potatoes and other foods. So it's an opportunity to integrate some of that messaging in there while you're also seeking to improve the diets of young children. Thanks.
Great. So we've had a lot of questions about adolescents, about, how do you incorporate messaging or targeting for pregnant adolescents because of their unique nutrient and mental health considerations. And yeah, I think we've had 3 separate questions about adolescents. So is there anybody, country programs or otherwise, who would like to talk about their experiences with working with adolescent population? Shonita, I see you've come on camera.
Yeah, thank you so much, Charlotte. For adolescents, for RAS in Karamoja, that's New York and Apollo, what we do, our mother care group approach actually doesn't discriminate the adolescents. So provided a mother is pregnant, be it an adolescent or an adult mother, is welcome to a mother care group. So it's inclusive of the adolescents. So these adolescents, if they're pregnant, they will then learn from other mothers on the key practices. So it encourages that peer-to-peer learning of the adolescents with other mothers within the mother care group. Also within the Apple activity, we have the adolescent safe spaces. And here, these are at community level. So within these safe spaces, adolescents are able to access nutrition counseling, nutrition education, nutrition assessment. So these, these spaces are specific. So it's adolescent specific intervention, where adolescents receive timely and targeted interventions that really relate to their situation as adolescents, because they're really a special and unique age group. Yeah, I think that's what I can say. So Apple really targets them directly through the adolescent safe spaces, while New York has the inclusive approach of engaging them through the mother care group. Thank you so much.
Thank you. Yes, Kristen.
I just want to say with working on adolescence is such an important, especially as we look more to pre-conception needs, dealing with women throughout the life cycle. And I just wanted to point people to a resource. There is an adolescent nutrition resource bank, and I can put a link to it in the chat, that gathers all kinds of over 200 resources on adolescent nutrition programming that I think could be valuable as we work to try to strengthen adolescent nutrition programming, making sure that we treat adolescents as the unique individuals they are, not just little adults, but they are very specific, unique needs to work with this group. So I can put a link to that in the chat that people might find useful.
Great, thank you. Wilson, it looked like you were coming off mute to chime in. Did you have something to add?
Thanks. Just adding to what Juanita shared, we ensure the linkage between the safe spaces and mother care groups, especially when we find pregnant adolescents. They are always linked to the mother care group facilitators at the VHTs and the lead mothers to ensure they get the right messaging and support. Just adding to what Juanita said. Thank you.
Thank you. Okay, we've had a couple questions about recognizing the importance of, I believe, facility health worker, FHW, and with the reliance on they're doing the counseling and messaging, and what are the experiences with motivation or incentivizing or making sure their remuneration being paid appropriately? What have people's experience with making sure there isn't that overload work burden? Anybody? Hopefully oh, okay. Juanita?
Is that for the facility health workers or the community health?
Oh, well, I suppose it could be either, depending on who you're working with in your program. I think, either or.
Yeah, sure. Yeah, I will share the Karamoja experience with that. I know the health systems are really challenged with the human resource like numbers. You find that there are really few health workers at a health facility, maybe 2 of them, and then you expect them to conduct an integrated health outreach in a fat-rich area. So you find they are really overloaded, yes, with facility and also community level approaches like the integrated health outreaches. So this brings in a key challenge, but what we do for the facility level interventions, this is totally the work of the Ministry of Health. So it's the Ministry of Health to to pay for their job, to give them salaries and all this, and also to avoid project-based dependency. We try to avoid giving them money, just to do their work. So what we do, we just support them with logistics, key logistics needed, like I highlighted in our presentation. We do support them, for example, with the anthropometric equipment. So we look at their needs, and we do support to provide some of the missing links for them to be able to provide efficient services. So we come in to ensure that they have that motivation. Like when they have what they need, then they will be able to offer quality services to the communities. So we try to avoid monetary motivation, but we do more of in-kind motivation to the health workers. And this also goes at community level with the VHTs in Uganda, the VH health teams, the frontline community health workers. So we do less of monetary, more of in-kind, and also we engage them in training, building their capacity. We work closely with the Ministry of Health. If we see a capacity gap, we train them. All these have proved to be great motivations for the health workers. Over. Thank you.
Thank you. And I have just been told the frontline health workers is what the F stands for. Sorry about that. So Maggie and I know Justine wanted to talk. We also have Raul, but Maggie first.
So in Guatemala, one of the incentives that we have used is providing 25 credits, learning credit course as part of the training, which is a motivator. It is an incentive to participate in training and recognition. Certificates mean a lot, and they do get a certificate, which is a motivator. We likewise, we do not provide money as an incentive or, but rather training and build capacities and opportunities for learning and exchange. Those are some of the key strategies being used. Right now, we're linking the training diplomado with mentorship. That was also another motivator, to have mentorship and participation in the community of practices. Over.
Thank you. Justine and then Ryle.
Yeah, thanks. Just to add on to that, I think, you know, a lot of times it's not necessarily always about payment. It's about how they're feeling appreciated as health workers and valued for their skill sets. And I think we do need to know more about what motivates providers, what is part of their behavior change, and what is sustainable in terms of how they are really critical to the quality of care that they're providing. And so some of the things we've done at MCSP is managing case workload, client flow, you know, in terms of the hours in which they're seeing certain antenatal care patients, for example, examining at the time providers have to counsel. We found that when you have facility providers that also are supported by community health workers and community providers, the quality of services is not only richer, but then it also unburdens the time a bit, depending on the topic that you're dealing with. So those are some strategies, but certainly there's a lot more work that needs to be done.
Thank you. And Raul, we'll finish with you and then wrap up.
Thank you so much, Charlotte. For Kenya, for the community health volunteers, what we do, we do the capacity building. We provide them with information so that they are also empowered, which is a motivation. Then secondly, there is a stipend that currently we are giving them just as a motivation to appreciate them. It's not really a pay, but a small stipend like $20 per month to appreciate them for the work and the sacrifice they are doing, because they do a lot of work doing home visits to be able to gather a lot and provide information to the community. Thank you, and over.
Thank you. And we are at the hour. As a reminder, core group will send out a recording and the presentations or a link to them. They'll be on the website. Avani, any last housekeeping? I want to thank, but first I'll thank our presenters and everyone who took the time to join us today. And I did put a link in the chat for the core group website where you can sign up for any of the working groups or interest groups. It's a direct link to that page with directions. So thank you, everyone. And